Good morning. It's a pleasure to present our work in the International Research Awards on Neurology and Neuro Disorders under the category of Best Researcher Award. I am Dr. Tanvi Shukla. I am from Cambridge University Hospitals NHS Foundation Trust, United Kingdom. We have studied impact of JME on quality of life, and we wanted to know that does a well-controlled epilepsy also hamper the psychological well-being and quality of life of the people? This study was carried out in GB Pant Hospital, New Delhi, which comes under University of Delhi. Introduction. Epilepsy is a stigmatizing disorder. It affects the quality of life and psychological well-being of the people affected with it. There have been numerous studies done in the past which on the quality of life of patients with intractable epilepsy. But we have studied quality of life and psychological comorbidities in patients with juvenile myoclonic epilepsy, which is a well-controlled form of epilepsy. In JME, seizure freedom is achieved in 70 to 85% of patients with anti-epileptic medications. The evidences suggest that JME people have better quality of life, but patients with JME have concerns pertaining to long duration of treatment and drug-related side effects. They have anxiety, depression, adjustment issues with family, which affects quality of life negatively. Early addressal to these issues and providing a comprehensive treatment to these patients is of paramount importance. Moreover, adults and adolescents needs to be assessed separately owing to their age-specific concerns pertaining to disease. Juvenile myoclonic epilepsy is a primary generalized form of epilepsy. It is a common form of epilepsy which affects 5 to 11% of the epilepsy cases. The age of onset is between 12 to 18 years of the age. It is characterized by myoclonic seizures, generalized tonic-clonic seizures, and less frequently the absence seizures. It has typical sleep and wake pattern with seizures. Aims and objectives of our study: to study the quality of life in patients with JME with special emphasis on physical, social, emotional, psychological, relationships and vocational aspects of the life. To study the association of gender, age, religion, socioeconomic status, educational status, duration of epilepsy, age at seizure control, anti-epileptic drug treatment, drug compliance, and seizure control with quality of life in patients with JME. Then to screen the patients with JME for associated psychiatric comorbidities and to evaluate in detail for psychiatric comorbidities if screening was positive. Materials and methods. This study was a hospital-based cross-sectional observational study. The informed written consent was taken from every patient before inclusion into the study. Ethical clearance was taken from a committee before commencing the study. There were 50 outdoor patients selected for the study who has diagnosis of JME from a period of June 2020 to December 2021. Inclusion criteria: diagnosis of JME as per ILAE criteria. Exclusion criteria: mental retardation, dementia, stroke or any other neurological illness, any recent history of traumatic brain injury, patients with substance abuse, with systemic illness or with psychiatric illness which have been diagnosed prior to the onset of epilepsy. Detailed history and examination was taken from each patient. A special emphasis in the history was given on age of onset, seizure type, frequency, family history of seizure, anti-epileptic drug treatment, and seizure control. Following scales were used to assess the quality of life. QALY 31P was used in adults and actually in all the patients. QALY AD48 was used specifically in adolescent patients from the age 11 to 17 years of age. QALY 31P it was used to assess the adult patients. It includes 6 subscales, that is the energy, mood, daily activity, cognition, medication effects, and seizure worry. Individual subscale scores were calculated and then combined to have a final score. QALY AD48 it was used for adolescent patient in the age group of 11 to 17 years of age. It has 8 subscales: epilepsy impact, memory, physical functioning, stigma, social support, social behavior, attitude towards epilepsy, and health perception. Individual subscale scores were calculated and then combined to give the final score. Both QALY 31P and AD48 were scored from 0 to 100. Higher scores indicate better quality of life. We categorize these scores as poor, fair, and good. That is, the scores 0 to 49 were poor, 50 to 74 were fair, and 75 to 100 were good. For screening psychiatric comorbidities, we used mini version 7.02, that is the mini International Neuropsychiatric Interview, and BPRS, that is the Brief Psychiatric Rating Scale. These scales are effective, quick, and low cost screening tools for the presence or absence of any psychiatric comorbidity. Those patients in which screening test was positive for any of the psychiatric comorbidities, they were evaluated and classified using DSM-5 and ICD-10 criteria. For the purpose of our study, we have divided patients into either controlled or uncontrolled epilepsy on the basis of whether they have seizures in last 6 months or not. The statistical analysis was done using SPSS version 22.0. Quantitative variables were measured using mean, and qualitative variables were measured using proportions. The clinical and demographic characteristics of our population. Median age of the population was 24.6. There was female preponderance with male is to female ratio being 1 is to 1.7. Family history of GTCS was present in 32% of patients. Mean age at seizure onset was 15. Mean duration of epilepsy when the study was taken was 9 years. In terms of seizure type, 84% of patients had both GTCS and myoclonus. 16% of patients had only GTCS, and none of the patients had absent seizures. In terms of seizure frequency, in GTCS per year, 50% of patients had no GTCS in the last 1 year. 42% of patients had 1 to 12 GTCS in the last 1 year, while 8% of patients had more than 12 GTCS in the last 1 year. For myoclonic jerk frequency, 23.8% patients had no myoclonus in last 1 month. 66.6% patients had 1 to 10 myoclonus in last 1 month, and 9.54% patients had more than 10 myoclonus in last 1 month. For seizure control, 36% had controlled epilepsy, while 64% had uncontrolled epilepsy. EEG abnormalities were present in 74% of the patients. In 66% of the patients, there was spontaneous polyspike and wave discharges, while in 8% of the patients, the discharges were present only after the activating procedures. 64% of the patients were in the monotherapy group, while 36% were having polytherapy. In the treatment compliance, 62% patients were compliant to their treatment. Assessment of quality of life. The time gap from last seizure to the assessment of quality of life, in 16% of patients it was 1 month, less than 1 month. In 18% of patients it was 1 to 6 months, and in 66% of the patient it was more than 6 months. The mean quality 31P score were 64.65. These scores were poor in 18% of patients, fair in 54% of patients, and good in 28% of patients. If we consider Quali 31P subscore, then in the medication side effects and seizure worry, people do poorly, while in energy and mood subscores, they did better. Quali 8048 score was done in adolescent patients. So basically, Quali 8048 score was calculated in addition to Quali 31P score in 8 patients who were in adolescent age group, that is from 11 to 17 years of age. Mean Quali 48 AD score in these patients was 16.15. It was poor in 12.5% patients, it was fair in 50% of patients, and it was good in 37.5% of patients. If we see the subscale scores of Quali 8048 scales, then for stigma and social support, people had a better score, while for attitude towards epilepsy, people had a worse score. For the psychiatric comorbidities, the presence or absence of psychiatric comorbidities was screened through mini and BPRS tools. Anxiety and depression both were present in 78% of the patients on screening. Only anxiety was present in 12% of the patients, and there were no psychiatric comorbidities in 10% of the patients. Presence of psychiatric comorbidities in relation to gender. In the male population, 78% of patients had psychiatric comorbidities, while in the female population, 97% of the females had psychiatric comorbidities. Severity of the psychiatric comorbidities. So it was very mild in 15.6% of the patients, mild in 44.4% of the patients, and moderate in 40.4% of the patients. The pickup rate of Mini and BPRS was equal, and they were equally effective in screening anxiety and depression. Psychiatric comorbidities fulfilling the diagnostic criteria ICD-10 and DSM-5. On applying the diagnostic criteria on all the patients who screened positive for the psychiatric comorbidities, only 11.11% patients were positive for anxiety, and only 2.56% patients were positive for depression. Variables affecting psychiatric comorbidities. Presence or absence of psychiatric comorbidities was affected by the gender. So it was more in female, and it had a female preponderance, that is 97% of female patients had psychiatric comorbidities. However, it was not affected by age, educational status, seizure frequency, and seizure control. Now, we see the association of QALY-31P score with other variables. So, association with age. In patients who were less than 17 years of the age, the QALY-31P score was 68, while in 18 to 39 years of the age it was 65, and for more than 40 years of the age it was 54. So the highest score of QALY was in the adolescents, but this difference was statistically insignificant. QALY-31P scores were comparable in male and females, and they were comparable in different socioeconomic status and different educational status. Association of QALY-31P score with frequency of GTCS. Association with frequency of GTCS. The patients with no seizures in last 1 year, the QALY-31P score was 62, in which there were 1 to 12 seizures in last 1 year, the score was 60, and in those with more than 12 seizures in last 1 year, the score was very low, that is 45. This suggests poor quality of life with higher seizure frequency. However, the p-value was more than 0.05. But on applying the Pearson's correlation coefficient in these patients, the R value was minus 0.188, which suggests negative correlation between seizure frequency and QALY-31P score, and it suggests poor quality of life associated with higher seizure frequency. Now, association of QALY-31P score with frequency of myoclonic seizures. Like generalized tonic-clonic seizures, we also studied the association of frequency of myoclonic seizures. Those patients in which there were no myoclonic seizures in last 1 month, the score was 69. In those with 1 to 10 myoclonic seizures in last 1 month, the score was 62. And those with more than 10 myoclonic seizures in last 1 month, the score was 58. Again, those with higher frequency did poorly on the QALY-31P scores, and this suggests a negative impact of higher seizure frequency on the quality of life. However, this difference was statistically insignificant. Association of QALY-31P score with control of epilepsy. In control group, in which the number of seizures in the last 6 months was none of the seizures, the QALY-31P score was 67, while in uncontrolled epilepsy, it was 63.05. The p-value was 0.046, that means the difference was statistically significant. Patients with uncontrolled epilepsy had a significant lower quality of life scores. Monotherapy versus polytherapy did not significantly influence the quality of life score with a p-value of 0.238. The statistical results of QALY-AD48 scores were in tandem with the QALY-31P scores across all the JME associated variables, except that the scores were better in the polytherapy group in the adolescent, although the difference was not statistically significant with a p-value of 0.802. Key findings in our study: there was female preponderance, The quality of life was affected in JME patients in a similar way as in the previous studies. However, there was poor quality of life pertaining to seizure worry and medication side effects. The population homogeneously believes that being affected with epilepsy entails a lifelong dependence on anti seizure medications, accompanied by apprehension of being exposed to their side effects. Also, female patients had more seizure worry for the aspects concerning to their marriage and fertility issues if they were unmarried, married, and for the concerns for managing the family if they were married. For adolescents, half of the patients had fair quality of life. The adolescents in India tend to have better social support, and this was reflected in their Quali AD48 scores as well. They have poorer scores belonging to the attitude towards epilepsy, that is, what they think about epilepsy and what they think about themselves of being an epileptic. So, there's an importance of epilepsy education in younger population which can help them to build a good attitude towards epilepsy. Also, poor seizure control was associated with poor quality of life in all the patients. For psychiatric comorbidities like anxiety and depression was common in JME patients as a result is common in JME patient as a result of mesial frontal lobe dysfunction, which has been seen in multiple studies done before. In previous studies, prevalence of psychiatric comorbidities ranged from 24.4 to 54%. In our study on applying the screening tools, the psychiatric comorbidities were detected in only 90% of the patients, but using the diagnostic criteria, the percentage came down to 15%. In our study, prevalence of anxiety was more than depression. However, overall prevalence of psychiatric comorbidities was lesser as compared to previous studies. Due to the selection bias and a large number of cases with controlled group epilepsy in our study, we had this difference from the others from the previous studies. Although symptoms of psychiatric comorbidities might not be sufficiently enough to warrant syndromic diagnosis in many of the patients, but they definitely affects the psychological well-being of the patients, and this require a need of cognitive behavior therapy and counseling in all the patients with epilepsy. Strengths of our study: consideration of subgroups within the JME population. Quality of life was compared between varying educational and socioeconomic status. Quality of life was compared between the controlled uncontrolled group and monotherapy versus polytherapy group. We have assessed quality of life among both adults and adolescents, considering these groups have different concerns pertaining to epilepsy. Also, as we have excluded patients with substance abuse and previous psychiatric diagnosis before the diagnosis of epilepsy, the homogeneity of the study population is also a potential strength. Limitation of our study: both mini version 7.02 and BPRS screens for impulsivity, but this domain was not separately assessed in our study, and this remain a possible limitations of the study. In conclusion, in our study, the quality of life was majorly fair in JME patients. Medication side effects and seizure worry remain an important aspect which affects the quality of life in these patients and needs addressal in all the patients. Although syndromic diagnosis of anxiety and depression was fulfilled in minority of the patients, majority of our JME cases have their mental and emotional and social issues on screening, which add to the burden of epilepsy and need to be identified and treated timely. Treatment of JME should not just focus on anti-seizure medications, but also should address the associated psychiatric comorbidities and the psychological impact of seizure as well. Selective cases may require cognitive behavior therapy or other strategies as the part of the therapeutic intervention, but all cases do need social and psychological support to enhance the quality of life. In all, I would say that too many rules can make the life unbearable. So it is important that we have sympathy towards the patients with epilepsy and we do not restrict them to the level that their quality of life becomes worse. I acknowledge all the authors of the study. Also, there was no specific funding received for this work and there were no conflicts of interest. I would again thank the organizer of the International Research Awards and Neurology of Neurology and Neuro Disorders for giving me this opportunity to present my paper. And this is my paper, and you can get it through this address. Thank you.